Yes, sir. Yes, sir.
అమరేంద్ర
సార్
వీడియో తిప్పమ్మా నువ్వు అటువైపు అది
ఉన్నానా సార్?
ఉన్నావు.
ఓకే సార్.
సార్ అందరికి మ్యూట్ చేస్తున్నా సార్ ఇప్పుడు.
యా గో అహెడ్.
గుడ్ మార్నింగ్ ఎవ్రీవన్.
ఆయనకి కూడా మ్యూట్ అయినట్టుంది చూడండి. బషీర్
సార్, అమర్ సార్ ప్లీజ్ స్టార్ట్.
సార్
స్టార్ట్. Amarendra, just 1 minute before we start.
Okay, sir.
I think we are live.
Yes, sir. Yes, sir. Yes.
Good morning, delegates. Welcome to the second day's program of CME 2020. Today we have 2 sessions. The first session is mainly about COVID and its complications, and followed by a nephrology session, nephrology talk by Dr. Pavan. And we have 2 more sessions coming up from 12 p.m. One is obstetrics and gynecology session, followed by pediatric session. Pediatric session followed by obstetrics and gynecology. I hand over to Dr. Amarendra and Dr. Dakshinamurthy garu, senior physician of Tenali IMA, to conduct the proceedings for today's first session. Thank you.
Good morning, respected doctors. Very good morning to all of you. Today we are about to start the day 2 session of CME conducted by Tenali IMA. I would like to invite our senior beloved Dr. Dakshinamurthy garu and our respected Dr. Sagar to the CME. Coming to Dr. Sagar, he is a renowned physician, pulmonologist in Vijayawada, who is a senior of mine during my MBBS days. Welcome, sir. Welcome, Sagar, sir. He studied his MBBS in Carter Medical College from 2003 to 2010, followed by which he did pulmonary medicine from Pinamneni Institute of Medical Sciences in 2015, followed by which he worked as a senior resident in same college for over 1 year. Since then, he is working as a senior resident there. At the same time, he joined in Capital Hospital over the last 1 year, and during which he discharged his services during the COVID times in a very respectful way. Thank you, one and all. Sagar sir, you can start the CME, sir.
హలో
సార్, దక్షిణమూర్తి గారు.
అవునండి. హలో,
యూ కెన్ సే సంథింగ్ సార్.
హలో హలో
దక్షిణామూర్తి గారు, మీరు మాట్లాడండి సార్. మీరు మాట్లాడితే సాగర్ గారు స్టార్ట్ చేస్తారు.
నాది రావట్లేదే. నాకు
వస్తుంది, మాట్లాడండి. మీరు ఫోన్ దగ్గరగా పెట్టుకుని మాట్లాడండి. యా, స్పీక్ సార్, స్పీక్.
మీ మాటలు వినపడుతున్నాయి సార్, మాట్లాడండి.
యూ కెన్ స్పీక్ సార్. యు ఆర్ విజిబుల్ అండ్ ఆడిబుల్ టు ఆల్ ఆఫ్ us. దక్షిణమూర్తి గారు.
హలో, 1 minute
సార్, మీరు మాట వినిపిస్తుంది, మీరు స్టార్ట్ చేయొచ్చు.
నా వాయిస్ వినపడుతుందా?
Yes sir, you are audible to all of us.
Yes. Respected Dr. Sagar, President and Secretary of Tenali IMA, Co-Chairman, and also colleagues, I am happy to
వీడియో కోసం ట్రై చేస్తున్నారా?
It's okay, sir. Raman పంపించాను. We'll get back, sir. We'll take his word before we start.
Okay, sir. As it is.
రామం రాండి
వచ్చింది.
రామిరెడ్డి గారు అందరూ
సార్ వచ్చింది, కనపడుతుందండి. You are audible and
కనపడుతుందా?
visible. You are audible and visible, sir. You can go ahead.
I already spoke. You did not hear.
You
I have
can
to start now.
Yes,
Yes, sir. Yes, sir.
Ramireddy garu.
we
Sorry for
start
the
now.
disturbance.
No problem, sir.
Yes.
No problem.
Dear Dr. Ratnasagar, President, Secretary of the IMA, Co-Chairman, and all colleagues, I'm happy to chair this session. British Institute of Clinical Excellence and Care, they divided COVID disease into 3 categories. That is, usually COVID lasts not more than 1 month. They will be staying in convalescence. up to 1 month. Are you hearing, please?
Yeah.
Am I audible?
Yes, sir. You are
I'm
audible,
ready,
sir. Please continue, sir. Please continue. You are
You are
audible,
audible,
sir.
sir.
Yes.
You are audible.
Yes. The second category, if the symptoms persist after 1 month, that is fatigue, breathlessness, anosmia, loss of taste, muscle pains, muscle weakness, reduced memory, all those symptoms can persist after 1 month. That is second category. If the symptoms persist or new onset of symptoms after 12 weeks, that is 3 months, then it is called post-COVID syndrome or long COVID syndrome. They categorize. This syndrome, we have to exclude the other diseases. That is differential diagnosis. After excluding the differential diagnosis, then we can confirm that is long COVID syndrome. And the symptom, the same Institute of Care and Excellence, again divided into 4 categories. One category is damage to lungs and heart. The second one is post-intensive care syndrome. That is those who are admitted in intensive care with the ventilator support, they will have more symptoms. Post-ICU syndrome. Post-viral fatigue, third category. Fourth category, contingent COVID symptoms. These are the 4 categories. The pulmonologists, they did their best and they are doing their best during this COVID epidemic. So, pulmonologist Dr. Ratnasagar, very appropriate to invite him to speak on this good topic of post-COVID sequelae. Thank you. Sorry for the disturbance.
Thank you, sir. Good morning, everyone. I'm Dr. Sagar, consultant pulmonologist, Capital Hospitals. The topic assigned to me is post-COVID sequel. Before going into the topic, let us have a brief review of COVID-19. COVID-19, coronavirus disease, it was first isolated in Wuhan, China. It is a RNA virus. As it is an RNA virus, it is susceptible to several mutations. Recently, one of the more aggressive mutant strain was isolated in the UK. It was named as VUY202012/01. Actually, it is more infectious. According to the data, it is 70% more infectious than the existing strain. Hence, it is called as a novel coronavirus. Its incubation period is about 5 to 9 days, and majority cases are mild. It is spread by droplet, transmission is by droplet infection, respiratory droplets. Coming to the pathophysiology, this virus consists of a single-stranded RNA, which is surrounded by a membrane. On the surface of this membrane, there will be S proteins. When we inhale this virus, it enters into the alveolar sac, which consists of 3 types of epithelium, 3 types of cells, that is type 1 pneumocytes, type 2 pneumocytes, and alveolar macrophages. Type 1 pneumocytes are squamous epithelial cells. They are useful for gaseous exchange. Type 2 pneumocytes are cuboidal cells. Type 2 pneumocytes are cuboidal cells, which are used for surfactant production. And alveolar macrophages, as you all know, it will engulf the foreign microorganisms or any foreign particles, which is useful in developing immunity. This virus has a S protein on its membrane, which gets attached to the S2 receptor of the cuboidal cells, that is type 2 pneumocytes. As soon as it gets attached to it, it engulfs into the cell, and the mRNA transcription takes place, which results in the formation of polyploid proteins. These in turn will replicate the virus, and the small virus particles will again shed into the alveolar sac. That's why when the patient cough, he will shed small virus particles. That's why it become more infectious. As soon as the cell bursts, inflammatory cytokines will be released, and there will be vascular permeability. This causes plasma leakage into the alveolar bed, and this is the main reason for ARDS in patients with COVID-19. This is the pathophysiology of COVID-19. Coming to the symptoms, as you all know, we have to differentiate between the upper respiratory tract infection, that is normal flu, from COVID-19. The common symptoms associated with COVID-19 are cough, cold. Cough will be dry cough. Most of the times it will be dry cough, sir. Next one is nasal stuffiness and cold, fever, which may be high grade, dyspnea, may or may not be present. Most of the patients are associated with body pains or myalgias. Some may present with gastrointestinal symptoms like diarrhea, loss of appetite, and some are present with anosmia, loss of smell and loss of taste. Coming to the diagnosis. Diagnosis is by gold standard for a diagnosis of COVID-19 is RT-PCR. RT-PCR means reverse transcriptase polymerase chain reaction. In this, nasopharyngeal swab is taken, and its RNA is extracted from the sample, and through reverse transcriptase, the RNA is converted into DNA, to which the primers, illuminated primers, are attached, which is helpful in the diagnosis of COVID-19. Another test is HRCT. So, in our opinion, one should do both RT-PCR and HRCT in patients suspected with COVID-19, because we had seen a number of patients who are RT-PCR negative but CT suggestive of COVID. CT will be mostly peripheral subpleural ground glass opacities with or without consolidations. This is a classical feature of COVID-19. So if a patient comes with the symptoms of COVID, we have to do both RT-PCR and HRCT. Coming to the treatment, as you all know, these are the standard mode of treatment. First of all, coming to the antivirals, both injectables like remdesivir and oral medication like favipiravir. But as far as we are concerned, antivirals will be affected in the early part of the disease. Once the disease gets established and hypoxemia sets in, there is no very good role of antivirals. Coming to the steroids, methylprednisolone was the drug of choice. The dose and will be determined by the patient condition, as far as the condition of the patient and degree of hypoxemia is having. Other mode of treatment are the blood thinners, anticoagulants and antiplatelets, immunomodulators like tocilizumab, infliximab, etc. Some patients who is suspected to have pulmonary thrombolysis, we are doing low dose thrombolysis also. Along with it, plasma therapy is also working in some people. Other immune boosters and CRRT. This is a new mode of treatment. This will be discussed by my fellow colleague Dr. Pawan Garu in the later session. This is used to remove the inflammatory cytokines from the blood of the COVID patient. Is by hand hygiene, respiratory hygiene, and social distancing, and avoiding non-essential travel. This is the brief overview of the COVID-19. Actually, COVID-19 is a multi-system disease. It is not only involving respiratory system, but also involving other systems. Common manifestations in post-COVID patients are the pulmonary manifestations are mainly two pulmonary manifestations. One is pulmonary fibrosis, and the second one is a vascular disease. Coming to neurological manifestations. Neurological manifestations we had observed in post-COVID patients are headache, delirium tremors, CVA, seizures, GBS, Miller-Fisher syndrome, and atonia. Coming to the cardiovascular manifestations. Cardiovascular manifestations are, we had seen n number of myocarditis patients in post-COVID patients. Arrhythmias, myocardial infarction, myocarditis, and heart failure. Due to prolonged stay in hospitals and in ICU, many of the patients had psychiatric manifestations like depression, bipolar disorder, psychosis, post-traumatic stress disorder, obsessive compulsive disorder, and Alzheimer's disease. Coming to miscellaneous, both fatigue and insomnia we had observed in more than 40% of the patients who are treated with COVID. Joint and post-viral arthritis is also very common. Chest pain, headache, and loss of appetite are the other antecedent symptoms. Coming to our topic, pulmonary fibrosis. What is the incidence of pulmonary fibrosis in post-COVID patients? It is generally less than 5 to 10%. What is the natural history of post-COVID pulmonary fibrosis? Generally, pulmonary fibrosis is a progressive disease. But what we had observed is, in post-COVID patients, pulmonary fibrosis is not progressive. And the modalities of the treatment will be discussed in the latter part. So the incidence is less than 10% of the total population who are admitted as IP. Coming to risk factors, what are the risk factors for development of pulmonary fibrosis? First one is advanced age above 60. And second one is the severity of the illness. That means CT severity score of more than 15 or the lung involvement of more than 50% are more susceptible for development of pulmonary fibrosis. Third one is length of ICU stay and mechanical ventilation. This is also a key factor which is in which the patients may develop pulmonary fibrosis. Smoking causes continuous irritation of the epithelium and it induces inflammatory cytokines and fibroblasts. So patients who are smoking are also high susceptible of developing pulmonary fibrosis. Other one is chronic alcoholism. Actually, fibrosis is a recognizable sequel of ARDS, which is a common feature in COVID pneumonia. 40% of the patients with COVID-19 develop ARDS, and 20% of are severe, which may lead into pulmonary fibrosis. The average age is above 60. Advancing age is a risk factor for development of the pulmonary fibrosis. Coming to the etiology, the cause of fibrosis. As soon as the inflammatory cytokines are released, it tumor growth factor alpha, platelet-derived growth factor, and all the other inflammatory mediated cytokines. These will cause aggregation of the fibroblasts and extracellular membrane, which causes fibrosis and distortion of the architecture of the lung, with fibrosis and honeycombing. Pathology is epithelial. There will be the virus inserts the virus particles inserts the epithelial layer with reactive epithelial cells and causes diffuse alveolar damage. It may be vascular with microvascular damage, microthrombi, endothelitis, acute fibrinous and organizing pneumonia. It may be fibrotic with interstitial fibrosis. So both epithelium, vascular, and interstitium will get involved. What are the strategies to prevent post-COVID pulmonary fibrosis? First one is minimize the risk of ventilator-induced lung injury by using lung protective ventilatory strategies like maintaining low tidal volume, low inspiratory pressures, that is P plateau less than 30. Second one is educate the patient to limit exposure to environmental factors like air pollution. Third one is smoking cessation. Smoking cessation is very important in post-COVID patients, as it may continuously irritate the epithelium, which in turn causes aggregation of the fibroblasts and increase the formation of pulmonary fibrosis. Follow-up PFT, pulmonary function test, may reveal a restrictive pattern. Follow-up PFT, 6-minute walk test, SpO2 levels, and HRCT are very important in excluding the pulmonary fibrosis. So, if the patient, follow-up patients is having any signs of dyspnea, chest discomfort, we have to do the PFT 6-minute walk test and we have to monitor his SpO2 levels, and repeat HRCT should be done if the SpO2 levels are below 90. PFT shows severe restriction and 6-minute walk test is severely altered. Coming to the pharmacotherapy in post-COVID pulmonary fibrosis. What is the dose and what is the duration and when to start? Actually, it is not known fully, but because it is not a common idiopathic pulmonary fibrosis, it is a post-COVID one, and when to start this antifibrotics and when to start steroids is absolutely dialectic. We should not use steroids routinely because steroids may cause immunosuppression. This in turn causes secondary infections. So when to start steroids, which conditions have to start steroids, which condition we have to start steroids will be discussed in the latter session. Coming to steroids, if steroids are indicated, what is the dose? It should be 0.5 mg per kg, that's prednisolone or equivalent dose of other steroids. It should be continued for at least 3 months. And if the prognosis is very good and the patient is responding, then we have to taper the dose. Otherwise, you have to start on antifibrotic medication like pirfenidone and nintedanib. Coming to the pirfenidone, it is a orally active synthetic antifibrotic agent. It inhibits the fibroblast, epidermal, platelet-derived, and transforming growth factors, and also it inhibits the collagen formation. This inhibition of epidermal, platelet-derived, and transforming growth factors causes its anti-inflammatory effect, and inhibition of the collagen formation causes antifibrotic effect. It has anti-inflammatory effect, antioxidant, and antifibrotic. What is the dose? Generally, the dose of pirfenidone is 200 mg TID in the first week, 400 mg TID in the second week, and from later on it will be 600 mg per TID later on until the response is very good. The dose should not exceed 2,500 mg per day. It is well absorbed orally, unchanged in urine, and hepatotoxicity, that is aminotransferase, serum aminotransferase levels. If the serum aminotransferase levels is more than three times above the upper normal limit, then we have to stop its usage, as it causes hepatitis. Other contraindications are, if creatinine clearance is less than 30, we should avoid this drug. Coming to nintedanib. It is a tyrosine kinase inhibitor, and it targets the growth factors like vascular endothelial growth factor, platelet-derived growth factors, which are potentially involved in the pulmonary fibrosis. Coming to the mechanism of action, it binds completely to ATP binding pocket of these receptors and block intracellular signaling, which is crucial for proliferation, migration, and transformation of fibroblasts. Coming to the dose is 150 mg BID dose, and adverse effects, most common side effects you had observed while using nintedanib is diarrhea. Others are nausea, abdominal pain, elevated liver enzymes, vomitings, and decreased appetite. Coming to the vascular manifestations. The main events occurring in post-COVID patients are stasis, endothelitis, and hypercoagulability. This causes microthrombi formation and chronic thromboembolism. In which patients the extended prophylaxis is needed. Extended VT all the patients. This is indicated in high risk. What are the first one is older age, second one cancer patients, third one is significantly reduced mobility, in which patients there is significantly reduced mobility, and in whom there is a prior history of DVT, and obese patients, and persons who had persistently elevated D-dimer. These are all the patients who are at high risk of developing VTE and pulmonary thromboembolism. So these patients should be started with prophylaxis. While using the anticoagulant, the bleeding risk to be assessed, to be assessed, and the duration is minimum 3 months. Following regimens are approved for the post prophylaxis. First one is rivaroxaban 10 mg daily. Second one is betrixaban 160 mg daily. Third one is apixaban 2.5 mg twice daily, or 5 mg once daily. These are all factor 10A inhibitors, which plays an important role in the coagulation cascade. So these are the approved drugs for usage in post-discharge prophylaxis as anticoagulants. Antiplatelet agents. In which patients you have to use antiplatelet agents? In known CAD patients, and these patients have high risk of developing cardiovascular events due to repeated inflammation. Other patients whom can use antiplatelet drugs are diabetic patients, hypertensive patients, and elderly patients. Other pulmonary complications involved in post-COVID patients are infections, as there is a meticulous use of steroids in COVID treatment. Post-COVID infections are mostly common. It may be bacterial and fungal. Most commonly, mucormycosis is a common organism we had isolated in post-COVID patients. Fungal pneumonias is also very common finding we had encountered in post-COVID patients. Due to this pulmonary fibrosis and architectural distortion and the decrease in hypoxemia, there is every chance of development of pulmonary arterial hypertension. These are the pulmonary complications what we had encountered in our daily practice. Till date, we had treated at about 600 IP cases and 2,500 OP cases, of which death percentage is less than 5%. These are the common complications we had encountered in post-COVID patients, mostly pulmonary fibrosis and chronic pulmonary thromboembolism. Thank you. I once of all thank IMA Tenali for giving me this opportunity on behalf of Capital Hospitals. Thank you, one and all.
అమరేంద్ర అన్మ్యూట్ చేయాలి.
దక్షిణామూర్తి గారు, హలో సార్.
Hello.
Sir, any questions, sir?
Dr. Sagar very nicely explained the complications like pulmonary fibrosis and also treatment. And this is going to be COVID-19 disease is going to be a long-term disease. We have to face it. So many complications can occur months after the acute onset. So, Dr. Amarendra, please ask the delegates to ask any
Thank you,
questions.
sir. Thank you very much, sir. Sagar, sir, how effective is pirfenidone, sir, in treating fibrosis compared to IDP?
90-10 is more effective than fibrocin. We had seen in our daily practice. Pirfenidone is little less effective. So, drug choice is 90-10.
Okay, sir.
So, in patients in post-COVID, 1 year it is enough.
Not audible, sir. Can you repeat it again?
1 year.
Audible. Hello?
Sir, చెప్పండి sir.
90-10 is more superior than pirfenidone.
Yes, sir. Yes, sir.
90-10 than pirfenidone.
Okay, sir. Thank you, sir.
Some not afford, so treat accordingly.
Okay, sir.
Hello.
Yes, someone is Samsudi garu.
Hello. By using these antifibrotic agents long time,
Sir?
by using these antifibrotic agents long time, they work specifically only in the lungs, or they will also act on the other organs also antifibrotic action. If so, if it acts entirely on the body, they will have other bad side effects also when compared to preventing the pulmonary fibrosis.
Yes, sir.
Any clarification from anywhere, from other countries or in other areas of the, because it is a very short duration. Any theoretical effect, practically whatever we know.
If we use antifibrotics for more than 6 months, it may cause multi-system disorders. But
which one? Sorry, which one? Pardon. More than 6 months because.
కొంచెం దూరంగా ఉండి మాట్లాడండి సార్. ఇప్పుడు వినిపిస్తుంది సార్. ఇప్పుడు చెప్పండి సార్.
By using more than 6 months.
ఇప్పుడు మాట్లాడండి సాగర్ సార్, కొంచెం దూరంగా ఉండి మాట్లాడితే వినిపిస్తుంది.
Actually, side effects are more common if you use more than 6 months, sir. So frequent monitoring of the patients, that is monitoring for every 3 months is necessary, sir.
Generally, that is more dangerous in post-operative patients. The healing is very delayed because the healing comes with the fibroblastic proliferations.
Yes, sir. Yes, sir.
That is why I think one should be very cautious before giving, and definitely after seeing the value and other things, we have to compare and contrast the benefits and this also. And of course, with these 4 or 5 months, naturally we are getting from August only, I think nearly July, August mainly. These 4 or 5 months, how many pulmonary fibrosis patients proven in your hospital? Proven pulmonary fibrosis.
In our hospital, out of 600 IP patients, IP patients we had treated, most of all, almost 20%, 20 patients, sir, out of 600. Very less, sir.
20 patients less. Actually, because this pulmonary fibrosis also, what they say is less than 4 days of stay in ICU stay, almost 4%, and less than more as the increases, the stage increases. And one more thing is high flow nasal cannula, high volume oxygen also will produce pulmonary fibrosis, what the people says.
Yes, sir. Yes, sir.
Okay, thank you.
Sir, so the execution of the fibrosis, sir.
Okay, thank you.
Dr. Sagar,
Sir.
There aren't any studies to prove pirfenidone or any other antifibrotics in post-COVID. That is the first point I want to mention. Whatever we are doing is only, I think, out of experience or this one. I think there are no studies to prove.
Yes, sir.
How do you quantitate? How do you quantitate the fibrosis, pre and post? That is the second question.
Yes, sir.
And do you have any other sequelae apart from fibrosis, like any other complications like reactivation of tuberculosis or any other?
Yes, sir. I had seen in one patient there is a reactivation of tuberculosis, in which there is a disseminated tuberculosis, sir. Due to prolonged use of these steroids and high dose of steroids, there is every chance of getting reactivation of tuberculosis, sir. And the second question is about the studies, sir. As it is a new disease, there is no adequate data supporting antifibrotic effects, sir. But in daily practice, as we are prescribing this 90-danib and pirfenidone, sir, there is a little improvement in the pulmonary function test, sir.
How do you quantify fibrosis? Do you have any fibroscan or something like that?
No, sir. We are basing on pulmonary function tests only, sir.
Depending upon
Based on the FVC values.
Right. Okay.
Thank you, sir.
Are there any other questions from the delegates?
No, sir.
Shall we conclude this and shall we go to the next one?
Yes.
Okay. Thank you, Sagar sir. Thank you very much for your lecture. You gave a very detailed lecture regarding the sequelae. It's very enlightening. Thank you very much. Now I would like to invite Dr. Bhupal. Good morning, sir.
Good morning.
Dashnamurthy gar, shall I introduce him?
Yes, please introduce.
Okay, thank you, sir. Thank you very much, sir. Dr. Bhupal is a consultant physician in Capital Hospitals, Vijayawada. He is also working as an associate professor in Penn Institute of Medical Sciences at Chinakakani. He did his MBBS from NTR University from the year 2008, followed by which he did his PG from NRI Medical College in 2012, where he is my senior, followed by which he got his DM cardiology in NIMS Institute Hyderabad in 2016, during which he got in which entrance he got the state first rank. I got to remember that during my PG days. He is very professional and academic during his PG days also. He used to work very hard. Coming to his experience, He has performed more than 5,000 diagnostic coronary angiograms and CAT studies within this short time. He also performed around 1,000 angioplasties. He is the first to do balloon pericardectomy in Andhra Pradesh, and he is the first to perform post-MI VST device closure in Andhra Pradesh. He has also performed around 100 periodic interventions in conditions like ASD, PDA, and VSD device closures. He is also first to assist in more than 1,500 complex coronary interventions like bifurcation stenting, chronic total occlusions, and structural heart interventions like PBMV, PBAV, PBPV, and post-MI VSD closures. Coming to his publications, till now he has published. He has 4 publications and dissertation. I welcome you, Dr. Bhopal, and you can start your lecture.
Thank you, Dr. Amar, for your kind introduction, and I would like to thank
Bhopal.
Sir.
Sir, Chapan, sir.
Okay.
And then I want to
Sir.
Introduction. 2 lines.
Yeah.
I am Dr. Dastamurthy.
Sir, good morning, sir.
Senior physician in Tenali.
Good morning.
Good morning. Dr. Bhopal is well known in Tenali also as a cardiologist through Capital Hospital. Only 2 lines I will tell. COVID manifestations. It can cause acute myocarditis. It can cause acute coronary syndrome. It can cause heart failure, acute heart failure, chronic heart failure. That is, heart failure may develop newly or may develop in the persons with pre-existing heart disease. That is, previously the patient was suffering from heart disease, then the failure may be precipitated, or newly heart failure may develop. Similarly, arrhythmias, stress cardiomyopathy, and also thromboembolic. Therefore, I don't want to speak more. Very good cardiologist, Dr. Bhopal, I want him to speak.
So, first of all, I would like to thank Tenali IMA for giving me this opportunity to talk on COVID-19 and its effects on heart. So, basically, how does COVID-19 affect the heart? So there are many mechanisms. One is direct toxicity through ACE2 inhibitors, which are overexpressed on the heart. Then indirectly by hypoxemia mediated or due to supply-demand mismatch due to reduced LV function, and the secondary cytokine storm that is initiated by COVID-19 infection, and by disseminated intravascular coagulation in severely affected patients. So this all leads to various manifestations in the heart, like acute coronary syndrome, arrhythmias, myocarditis, venous thromboembolism, as Dr. Dakshinamurthy Garu has already mentioned, heart failure and cardiogenic shock. Coming to, sorry. Most common manifestation on heart is myocarditis. It appears in almost 70 to 80% of COVID-19 patients several days after initiation of fever. This one mechanism that has been postulated was upregulation of ACE2 receptors in the heart and coronary vessels. The second most common manifestation is ST segment elevation myocardial infarction. This is due to increased risk of plaque rupture and thrombus formation, resulting in either an ST segment elevation myocardial infarction or non-ST elevation myocardial infarction. And the next is myocardial injury with disseminated intravascular coagulation. As you know, disseminated intravascular coagulation is a life-threatening condition which is present in about 70% of non-survivors with COVID-19 and about 0.6% of survivors. So this itself indicates that disseminated intravascular coagulation is one of the most severe forms of involvement of COVID-19, and almost 70 to 80% of patients with disseminated intravascular coagulation succumb to this disease. So I would present this topic under the following headings: hypertension and COVID, biomarkers and COVID, acute coronary syndromes and COVID, myocarditis, heart failure, DVT and pulmonary thromboembolism, arrhythmias, drug interactions, and finally pericardial effusion. So coming to hypertension and COVID, as you know, COVID-19 attaches to affects the heart, mainly causing myocarditis through ACE2 receptors. So ACE2 is expressed in lungs, heart, and vessels. It is a key member of angiotensin system and is important in the pathophysiology of cardiovascular disease. And the prevalence of pre-existing hypertension seems to be higher in COVID-19 patients who develop severe disease versus those who do not. So hypertensives are more prone to severe COVID-19 infections, probably due to increased ACE2 receptors. But there was a speculation that RAS inhibitors, people taking RAS inhibitors, renin-angiotensin system inhibitors like ACE2 antagonists and ACE inhibitors and angiotensin receptor blockers upregulate ACE inhibitors over the myocardium, causing severe COVID-19 induced myocarditis. But recent observational study, which was done in about 8,000 patients from 169 hospitals in Asia, Europe, and North America, did not show a harmful association of ACE inhibitors or ARBs, though theoretically it is a possible mechanism. And a Wuhan study also demonstrated that in 1,100 patients, usage of ACE or ARB was associated with lower risk of COVID-19 infection or serious complication or deaths from COVID-19 infection. So ACE and ARBs can be safely continued. Initially, there was a misconception that people taking ACE inhibitors or ARBs need to be stopped from taking those medicines. But recently, after this data came up, so patients taking ACE inhibitors and ARBs need to continue them, and then need not be stopped. So there is no clear evidence that using ACEs or ARBs lead to upregulation of ACE2 in human tissues. To date, there is no clinical evidence to support this mechanism, and patients on ACE inhibitors or ARBs should not stop their treatment. Coming to biomarkers in COVID-19 infection, cardiac troponins and BNP concentration should be interpreted as quantitative variables. And in absence of typical angina, chest pain, or ischemic ECG changes, patients with mild elevations, that is less than 2 to 3 times the upper limit of normal, do not require workup or treatment for type 1 myocardial infarction. So mild elevations of troponin is a common finding in patients with COVID-19 infection, which need not be stressed upon, and they need not be further evaluated unless there is significant clinical correlation, like presence of typical anginal chest pain or presence of significant ECG changes. So D-dimer quantification quantifies activated coagulation due to endothelitis and thromboembolism, and serial measurements of troponin need to be done if there is suspicion of coronary artery disease in COVID-19 patients. Coming to in-hospital mortality, elevation of troponin, even though it is clinically insignificant, elevation of troponin T leads to increased mortality, and about 7.6% of patients without underlying cardiovascular disease, without underlying cardiovascular disease and normal troponin, the mortality rate is about 7.6%. And patients without cardiovascular disease and elevated troponin, as you can see, patients with elevated troponin levels but without cardiovascular disease, the mortality is as high as 37.5%, and patients with cardiovascular disease and elevated troponin, the mortality rate is almost 70%. So troponin T acts as a prognosticating marker in patients with COVID-19 infection. And coming to biomarkers of heart failure, As you know, the biomarker, most commonly used biomarker for assessing heart failure is BNP and NT-proBNP. So natriuretic peptides are basically biomarkers of myocardial stress, and they can be elevated in patients with severe respiratory illness due to increased right heart pressures, typically in absence of elevated filling pressures or clinical heart failure. So you can see BNP to be mildly elevated even in patients with COPD. And like troponin, elevation of BNP or NT-proBNP is associated with an unfavorable course among patients with ARDS. In COVID-19, patients often demonstrate significant elevation of BNP or NT-proBNP, and mild elevations are common due to increased right heart pressures due to extensive involvement of lungs. But significance of this finding is uncertain and should not necessarily trigger an evaluation or treatment for heart failure unless there is clear clinical evidence for diagnosis. Coming to comorbidities in COVID-19 infection, as already I have mentioned, so in one study that has been published in NEJM, hypertension was the most common comorbidity that has been observed, which was seen in 23% of patients who had severe COVID-19 infection. The second most common is diabetes, third is coronary heart disease, and the fourth is cerebrovascular disease. And in the another study, cerebrovascular disease was more common in severely infected patients, and then was diabetes. But majority of the studies showed that hypertensives are more prone to severe COVID-19 infection. Next comes diabetes. So patients with comorbidities like diabetes and hypertension are more prone to severe COVID-19 infection and are more likely to succumb to this infection. So, and the other diagnostic dilemma we face in COVID-19 times is identifying acute MI during COVID-19 era. So cardiovascular manifestations itself in COVID-19 are complex, and patients may present with acute MI, myocarditis, which may simulate a STEMI presentation. That is, some patients with myocarditis almost present exactly as ST elevation myocardial infarction, and patients with COVID may have stress cardiomyopathy. They may have non-ischemic cardiomyopathy. They may have coronary spasm or myocardial injury without a documented type 1 or type 2 acute MI. And patients testing for COVID-19 can be asymptomatic. So there are many asymptomatic COVID-19 patients, despite significant abnormalities noted on chest CT scan, and there appears to be significant risk of asymptomatic transmission of the disease. And patients with asymptomatic COVID-19 infection also may present with acute myocardial infarction. So coming to diagnosis of acute MI during COVID-19 era, coming to non-invasive imaging, we need, the guidelines suggest not to perform routine cardiac imaging in patients with suspected or confirmed COVID-19, and perform imaging studies in patients with suspected or confirmed COVID-19 only if the management is likely to be impacted by imaging result. So subject the patient to non-invasive imaging only when you suspect a cardiac involvement, and imaging protocol should be kept as short as possible to reduce the chance of transmission of infection. Coming to role of echocardiography, it only helps in decision making and findings which exclude the likelihood of ACS. When there is suspicion of ACS is no RWMA on 2D echo. Presence of pericardial effusion is unlikely in patients with acute coronary syndrome, and presence of regional valve motion abnormality not corresponding to any particular vascular territory indicates non-ischemic cardiomyopathy, and presence of global hypokinesia indicates non-ischemic cardiomyopathy. And the various non-invasive imaging modalities available are echo and transesophageal echo, and cardiac CT may be preferred to TE in order to rule out left atrial appendage and intracardiac thrombus prior to cardioversion in case of arrhythmias. And CT coronary angiogram can be an alternative to conventional angiogram. Cardiac MR can be used for diagnosing myocarditis, and exercise testing can be done. So in COVID-19 era, the challenges we face for treating patients with acute MI is mostly patient delay due to lack of transport, fear of contacting infection from hospital, and unavailability of primary care services, especially to COVID-19 patients, and diagnostic dilemma arising due to abnormal troponin due to myocarditis. So many of the patients with elevated COVID-19 infections with elevated troponins are diagnosed to have acute myocardial infarctions, and they have been shifted to cardiac centers. But majority of times it is myocarditis rather than a coronary event, and a shortage of PPE, and the need to reassess risk benefit ratio of optimal STEMI management. So basically, you need to be very careful while diagnosing an ST elevation MI in patients with COVID-19, and management also needs to be careful to prioritize, I mean, risk benefit ratio. So so basically, if patient has definite ST elevation MI, and if it is a PCI center, and primary PCI needs to be done with level 2 PPE, and if the duration is greater than if 2 hours to shift to a PCI center, then probably pharmaco-invasive strategy is suitable. That is, thrombolize initially and shift the patient to a PCI-enabled center, PCI-enabled COVID center. Then if there is a diagnostic dilemma, if you are suspecting probable STEMI or STEMI mimics, observe and better do conservative management, avoiding too much exposure to cath lab staff. If the patient is very sick and the prognosis is very poor, and if the patient develops MI on ventilator or such kind of a thing, better go for conservative management. And if the patient has extensive interval MI with cardiogenic shock or out of hospital cardiac arrest, better go for conservative management in order to reduce exposure to healthcare workers. And if there is a non-ST elevation MI or unstable angina, try conservative management, postpone angiogram. Only if patient is sick or if there is any hemodynamic alteration, go for a coronary angiogram. So basically, this is the flow chart which you need to follow. So whenever there is whenever you identify an ST elevation MI, if you are able to transfer the patient to a PCI enabled center within 2 hours, better transfer to a primary PCI center. If you are unable to transfer the patient to a PCI enabled center within 2 hours, better do thrombolysis and then shift the patient to a PCI enabled center. So these are the scenarios when you need to consider primary PCI, that is anterval STEMI, early presentation within 6 hours of chest pain, and relatively young patient who can be revived, and then there is low clinical probability of COVID-19 during COVID-19 era. And patients with non-ST elevation MI, they need to be conservatively managed. Only they need to be subjected to angiogram only when there are hemodynamic derangement, or patient is in refractory heart failure, which cannot be managed medically. So then patients with acute heart failure. So underlying mechanisms of acute heart failure in COVID-19 may include acute myocardial ischemia, as mentioned, ARDS, acute kidney injury and hypervolemia, stress-induced cardiomyopathy, myocarditis, and arrhythmias leading to acute heart failure. There will be significantly elevated BNP or NT-proBNP, and treatment strategy does not differ much from non-COVID patients. So heart failure prevalence was significantly higher in fatal cases compared with survivors. And most important thing is the diagnostic dilemma. As we might have seen, many patients with pulmonary edema have been rejected for treatment during this COVID-19 era, considering falsely diagnosing them with COVID-19. And many patients have suffered, many cardiac patients have suffered during this pandemic for lack of treatment. because they were falsely diagnosed to have falsely diagnosed with COVID-19 based on chest X-ray findings and HRCT findings, and they have been sent to COVID centers denying treatment for acute pulmonary edema, which should have been managed effectively. So coming to myocarditis should be suspected in patients with COVID-19 and acute onset chest pain, ST segment changes, arrhythmias, hemodynamic instability with global or multisegmental hypokinesia, elevated troponin and BNP, and CT coronary angiogram can be done to rule out coronary artery disease. Cardiac MR helps in quantifying the degree of involvement of myocardium, and endomyocardial biopsy is not routinely recommended in patients with myocarditis. And this was a study which has shown almost 78% involvement of myocardium in patients with COVID-19. So this itself indicates that heart is the most important organ, second to lungs, that is affected by COVID-19. So management of cardiomyopathy in COVID-19 patients, how do you manage? Avoid over-aggressive fluid resuscitation given challenges with oxygenation. So higher preloads may also be desirable when significant RV dysfunction or high PEEP states are present. So the ideal CVP to be maintained is 6 to 8 mm Hg, but when higher PEEP needs to be given, CVPs around 12 to 15 are acceptable. So the effective CVP can be calculated by measured CVP minus the PEEP which you set on the ventilator, and target a mean arterial pressure of 60 to 65 mm Hg, and consider dobutamine in the setting of worsening hypotension with cardiac dysfunction. Epinephrine and vasopressin should be considered for refractory hypotension, and consideration can be given to using angiotensin II for refractory vasoplasia, but angiotensin II is not routinely available. Coming to ECMO, ECMO is a very limited resource, and it should be reserved for those with greatest chance of recovery, especially young patients who have a good chance of recovery. Coming to another most important condition in COVID-19, that is DVT and acute pulmonary embolism. You need to consider anticoagulation as standard at standard prophylactic doses in all patients admitted with COVID-19 infection, as there is increased evidence of DVT even on anticoagulation. So coming to when do you need to suspect acute pulmonary embolism in COVID-19 patients? When you see unexpected respiratory worsening, or new or unexplained tachycardia, or a fall in BP which is not attributable to tachyarrhythmia, unexplained hypovolemia, or new onset ECG changes suggesting pulmonary embolism, and signs of DVT on extremities, you need to suspect acute pulmonary embolism. And patients in shock should receive immediate reperfusion therapy, that is thrombolysis, and hemodynamically stable patients may be treated with either unfractionated heparin or low molecular weight heparin. So this was a patient scenario at our hospital who got admitted with COVID-19, but later developed sudden onset breathlessness. His record showed dilated RA-RV with severe TR and severe PAH. Suspecting CT pulmonary angiogram showed clear-cut acute massive pulmonary embolism in the main pulmonary artery extending into left pulmonary artery. So he was given thrombolysis, after which he recovered. So this is the Mount Sinai COVID-19 anticoagulation algorithm. So whenever there is a high risk patient, that is patient who has increased oxygen requirement, increased D-dimer, increased creatinine, and increased CRP, and he is admitted to an ICU, better start him on enoxaparin 1 mg per kg BD, or put him on heparin infusion for a target APTT of 70 to 110. If patient is low risk, then start him on apixaban 2.5 to 5 mg BD or enoxaparin 40 mg once a day. If creatinine clearance is less than 50 and patient is on renal replacement therapy, that either in form of dialysis, he needs to be put on apixaban. Apixaban is preferred over heparin, as apixaban doesn't have renal clearance. So patients with renal failure need to be started on apixaban, where if creatinine clearance is greater than 50, he can be started on low molecular heparin or apixaban. So coming to arrhythmias, especially with the usage of QT prolonging drugs like azithromycin and hydroxychloroquine, arrhythmias should be carefully watched for. In hospitalized patients with AF or atrial flutter without hemodynamic instability, you need to discontinue all antiarrhythmic drugs and initiate rate control drugs. Beta blockers and non-dihydropyridine calcium channel blockers are preferred instead of antiarrhythmic drugs like amiodarone. To allow safe use of hydroxychloroquine or azithromycin as antiviral medication. And in critically ill patients with hemodynamic instability due to recurrent hemodynamically unstable VT or AF, IV amiodarone is the choice of antiarrhythmic medication. However, its combination with hydrochloroquine and azithromycin should be preferably avoided. And special attention should be paid to a prevention of Torsades de Pointes, which occurs due to long QT, especially when patient is on hydroxychloroquine and azithromycin in combination with antiarrhythmic drugs. Electrolyte disturbances, kidney dysfunction, or bradycardia should be carefully watched for. Therapy for Torsades includes IV magnesium supplementation and increasing potassium levels to greater than 4.5, and increasing heart rate by withdrawing bradycardic agents, and if needed by IV isoproterenol or temporary pacing. So we have seen patients who had Torsades de Pointes and refractory VT in patients who have taken hydroxychloroquine along with azithromycin. So these were the various arrhythmias observed in our hospital. Atrial fibrillation, one patient with atrial fibrillation, one patient with SVT. And bradycardia also is a common finding in patients with COVID-19, especially patients who have diseased AV node. Taking chloroquine, they may go into complete heart block. And in case of persistent symptomatic bradycardia due to AV block or recurrent sinus node dysfunction with pauses, all medication causing bradycardia should be stopped, and isoprenerin or atropine should be given as needed, and temporary pacemaker implantation should be considered. And after recovery from COVID-19 infection, need for permanent pacemaker implantation should be reassessed. So these are the various ECGs of patients who had significant bradycardia in our hospital. So so these are the contraindications to HCQ. Drug is contraindicated in persons with known cases of retinopathy and hypersensitivity to hydroxychloroquine, and patients with G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, and patients with pre-existing cardiomyopathy and cardiac rhythm disorders. And drug is not recommended for prophylaxis in children under 15 years of age and in pregnancy and lactation. So this is the flowchart for managing patients with long QT. Better avoid hydroxychloroquine and azithromycin in patients who have long QT, baseline long QT on ECG. So these are the various cardiovascular concerns and treatment options available. Summarizing, STEMI and NSTEMI patients, you need to judge between primary PCA or using thrombolysis. For patients with significant myocardial injury, they have worse prognosis, and patients with hypercoagulable states, put the patients on thromboprophylaxis. ACE or ARB use, continue treatment currently, await for further studies. Hydroxychloroquine and azithromycin, you need to closely monitor QT prolongation, and immunosuppression may be helpful in selected patients with cytokine storm. So cardiogenic shock, IABP or ECMO might be used. So during this COVID-19 era, better use pharmaco-invasive strategy to limit exposure to healthcare professionals. And myocardial injury is common in COVID-19, causing troponin elevation. Prefer echo only if it helps decision making, limit auscultation time, and most importantly, protect healthcare workers as they're a limited resource in this society. Thank you. I think if you have any questions, I think I can take questions.
I'm Dr. Dastamurthy.
Sir.
Hello. Am I audible?
Yes, sir. You are audible, sir.
Nice. Thank you, Dr. Gopal. Nice lecture. Two or three doubts, not doubts.
Yes, sir.
What you said. First, in early days, they said AC inverters and air-based should not be used in
Yes, sir.
COVID.
Yes, sir.
Later,
Yes.
as you said, thousands of patients were tested, clinical trials, and they
Yes, sir.
now concluded that they can be used. Therefore,
Yes,
it
sir.
is a good point for physicians' practice point of view and also general practitioners' point of view.
Yes, sir.
The second thing is during peak COVID season, that is May to September or October. Actually, heart attack cases, generally we general physicians only see heart attack patients here in towns like Tenali. But
Yes,
what happened to those patients, I don't know. Many of them might have died. And also, we cannot diagnose a STEMI. If you diagnose STEMI in the ECG, whether it is due to COVID or not, we have to test for a government hospital only.
Yes, sir.
The RT-PCR test is not available outside.
Yes,
So patients suffered so much.
Yes.
I suspect many patients might have died of
Yes,
heart
sir.
attack in the houses itself.
Yes, sir.
That is second question.
Yes,
Very
sir.
nice lecture.
Yes, sir.
Congratulations.
Thank you, sir.
Yes, sir. What you said is very much right, sir. Dashnamurthy garu. Even 10 to 15 patients have died due to MI secondary to COVID in the house itself, sir.
And the other problem was during the peak season, many of the patients with acute pulmonary edema were falsely diagnosed to have COVID based on X-ray or HRCT, and they were denied treatment in many hospitals, and they have been referred to COVID centers, and patients died meanwhile. So we have seen many patients succumb to cardiovascular disease, and I have been trying to educate many physicians in the society and many, many pulmonologists that, as you see, the mortality due to COVID is less than 2%, but mortality due to cardiovascular disease is almost 10 to 20% if you do not treat the patient in time. So that is what happened in many patients. So I feel sorry for that.
Yes, sir. They died in the home itself, sir. Many of them.
Yes, yes.
I've seen them, sir. Srikanth, sir, would you like to add anything? Hello?
No, Amar. No, Amar. Go ahead.
Okay, sir. Thank you, Gopal, sir. It's very informative and enlightening. Thank you very much for your CME. It's very good presentation. We all got very much enlightened. Thank you very much, sir.
Thank you. Thank you.
Next talk will be diabetes and COVID by Dr. K. Venkat Umakant garu. Is he there? Yeah. The chairperson will be Dr. Rahul Srinivas garu. Good morning, sir. Srinivas garu.
Good morning.
Sir, do you have Dr. Umakant's?
Yeah, I'll just introduce him.
Yes. Dr. Umakant, are you ready, sir?
Unmute,
Okay.
sir. Umakant garu.
Ready, sir.
Good morning, sir.
Good morning. Good morning.
Dr. Rahul Srinivas garu will be a chairperson for today's lecture, sir. He will take over from now.
Yes.
First of all, I thank the Tenali IMA, Dr. Sam Reddy garu and Srikanth garu for this beautiful opportunity. And I've been attending their lectures since yesterday. They have been very useful and practical. And sharing the local experiences rather than outside speakers has been very great. With this, a brief introduction of Dr. Venkat Umakant Kodali garu, who on the topic of diabetes and COVID, He started his career in medicine from Bijapur, Karnataka in 1992 and then proceeded to Kasturba Medical College as anesthesiologist, and subsequently in 2004 joined Khammam Mamta Medical College in General Medicine and continued as assistant professor, associate professor, and hence has a dual specialty of an anesthesiologist as well as a physician with good academician, with lot of papers, presentations, and has been in teaching for a long time. Apart from his short stints in Newcastle, Sydney, and Massachusetts, for his which he gained good experiences. And after resigning from teaching in 2013, worked in various hospitals in Vijayawada and is presently in Capital Hospital since 2017. And we look forward for an enlightening lecture on diabetes and COVID, which is a day in and out, not only for the physicians, for everybody who has seen and managing COVID. Please, Dr. Umakant.
Yeah, thank you, sir. Thank you for your kind words. At first, I would like to thank the IMA Tenali and Capital Hospitals for giving me this opportunity. So, managing the presentation. So this is where I work. Right. Let's go into the overview of this topic, COVID-19 and diabetes, special, general and specific precautions.
Slides share
Screen share your slides.
One second. Share screen. Sir, I am able to see, sir?
Yes. Please full screen, sir.
Yeah. Now, sir?
Yes.
Okay. So coming to the overview of the presentation, COVID-19 and diabetes, general and specific precautions in people with diabetes, measures in people with diabetes and COVID-19, use of insulins in times of COVID-19. So before going into the diabetes proper, let's refresh our knowledge. The term COVID-19 was coined by which organization? Mortality in people with diabetes who are infected with COVID-19 increases by how many times versus those without diabetes? These you can get in the subsequent slides. So escaping the Pandora's box, another novel coronavirus. In December 2019, an outbreak of unknown disease called pneumonia of unknown cause in Wuhan, China. The causative agent later identified as a novel coronavirus. The virus named as severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. Disease named as coronavirus disease 2019, that is COVID-19 by WHO. So this we have been explaining everyone day in and day out. So once again to refresh, exact dynamics had to be determined, person-to-person transmission, respiratory droplets or closed contact, mean incubation period 5 days, range 1 to 14 days. In 95% of cases, symptoms within 12.5 days of contact, and 1 person likely to infect 2.6%. So what are the symptoms? Spectrum of clinical presentations from asymptomatic infection to severe respiratory failure. Main symptoms include fever, fatigue, sore throat, dry cough, myalgia, and dyspnea. Uncommon symptoms, sputum production, headache, hemoptysis, and diarrhea. Although pneumonia is present in most, few cases complained of pleuritic chest pain. So interesting trivia about COVID-19 symptoms. 20% of COVID-19 patients in Wuhan did not have fever. 99 patients, mean age 55 years, from a hospital in Wuhan where the first patient with COVID-19 was admitted. Clinical manifestations: fever 83%, cough 82%, shortness of breath 31%, muscle aches 11%, confusion 9%, headache 8%, sore throat 5%, rhinorrhea 4%, chest pain 2%, diarrhea 2%, and nausea and vomiting 1%. Cough was the predominant symptom in COVID-19 patients in China outside Wuhan. There was a presentation of 62 patients with median age of 41 years admitted in the ICU in a Chinese province outside Wuhan. So most common symptoms at the onset of illness were cough, fever, expectoration, myalgia, fatigue, headache, diarrhea, and hemoptysis. Only one patient developed shortness of breath. Loss of sense of smell and taste may be early COVID-19 symptoms, may be a potential marker or a clue for COVID-19, only preliminary evidence, not conclusive. So let us address the following questions. Are all the people with diabetes more prone to contracting COVID-19? Do people with diabetes have worse outcomes? What precautions should people with diabetes take? So how does COVID-19 affect those with diabetes? Diabetes in 42.3% of 26 fatalities due to COVID-19 in Wuhan, China. A report of 72,314 cases of COVID-19 increased mortality in people with diabetes, 2.3% overall versus 7.3% with diabetes. That means you can see a threefold higher mortality rate in diabetes. Coexisting disease of heart, kidney, advanced age, frailty are likely to have further increase in the severity. So therefore, people with diabetes do face a higher chance of experiencing serious complications from COVID-19. So let us further examine the risk factors. Characteristics of and important lessons from the corona disease 2019, that is COVID-19 outbreak in China. Summary of a report of 72,314 cases, which I have already said in the previous slide, from Chinese Center of Disease Control and Prevention. The case fatality rate, that is the CFR, overall 2.3%. No deaths in 9 years and younger. 14.8% in patients aged 80 years. 8% in patients aged 70 to 79 years. But CFR with pre-existing comorbid conditions, 10.5% with cardiovascular disease, 7.3% with diabetes, 6.3% with chronic respiratory disease, 6% hypertensives, 5.6% other malignancies. So what are the general precautions to be taken? We day in and day out tell the patients, other healthcare providers, hand hygiene, respiratory hygiene, social distancing, avoid non-essential travel. So we need to break the chain to limit the spread. What are the specific precautions for people with diabetes? Good glycemic control, which reduces risk and severity of the infection. Frequent monitoring of the blood glucose levels. Stabilize cardiac and renal status, that is reduce chances of serious complications. Nutrition, correct deficiency with vitamins and minerals. Exercise, which improves immunity. Self-quarantine, especially in high-risk patients like elderly. Influenza and pneumonia vaccinations may lessen chances of secondary bacterial pneumonias. So what are the measures in patients of diabetes with COVID-19? Every day once this COVID-19 has started, you have seen many news in the papers. Everyone with diabetes must prepare for COVID-19. Glucose control is the key with COVID-19. Diabetes, cardiovascular disease tied to worse prognosis for COVID-19. So in case a person with diabetes develops symptoms, appropriate health authority needs to be notified. Affected person needs to be isolated for 14 days or till the symptoms resolve. Majority have a mild disease and can be managed. Current sick day guidelines for treatment of infections in patients with diabetes would extend to those who are diagnosed with COVID-19. So which of the following anti-diabetic medications should be considered for temporary dose reduction or discontinuation in seriously symptomatic patients with diabetes and COVID? Drugs causing volume contraction, drugs causing vomiting, drugs causing volume overload, all of the above. So this we'll be discussing in the subsequent slides. So what are the measures in patients of diabetes with COVID-19? Maintain hydration, symptomatic treatment with acetaminophen and supportive care like steam inhalation, etc. Possibly avoid ibuprofen. Anti-hyperglycemic agents that can cause volume depletion should be avoided. So insulin is the preferred agent for control of hyperglycemia in hospitalized patients. Avoid hypoglycemia, especially if chloroquine or HCQs based regimen. So insulin with lesser risk of hypoglycemia are the choice in a hospitalized patient. So precautions with anti-diabetic agents. Analyze the risk benefit individually. Metformins raise lactic acid levels, acidosis. SGL2 inhibitors volume contraction for fat metabolism, ketosis. GLP-1 receptor antagonist can cause vomiting, and pioglitazone can cause volume overload. So how to control hyperglycemia in sick patients where dose of other anti-diabetic medications is reduced or withdrawn? In all patients where anti-hyperglycemic medications are being considered for temporary dose reduction or discontinuation, basal insulin with or without a bolus is to be used to maintain good glycemic control. So insulin remains the drug of choice in sick patients. So what are the guideline recommendations on initiation of insulin? So let it be ADA, IDF, CDA, NICE, RSS, DI. All the studies guidelines are unanimous in recommending basal insulin at initiation. Second generation basal insulin can offer additional benefit of lesser hypoglycemia, lesser variability, safe titration, and greater flexibility. So the ADA guidelines 2020 recommend basal insulin as the most convenient insulin regimen in patients with type 2 diabetes mellitus. So what are the 7 vital T's for basal insulin use in type 2 diabetes mellitus? That is the 7T concept. So first one is treatment initiation. Basal only regimen is the most convenient initial insulin regimen. This leads to reduction in complications and improvement in outcomes. The basal insulin should be injected at the appropriate time, usually at bedtime. Longer acting basal insulin can be administered at any time of the day. Third, target for titration. Titration of insulin dose is recommended to reach a predefined therapeutic goal of fasting plasma glucose and the A1C levels. Oral medications. Combination therapies of oral antidiabetics and basal insulin after complementary mechanisms of action that can maximize efficacy, reach target goals, and minimize adverse events. What are the tools for monitoring and troubleshooting? Basal insulin analogs are associated with least risk of hypoglycemia, which can further reduce with timely initiation, proper patient education, and regular monitoring. Transportation and storage. Insulin vials, cartridges, pens may be kept at room temperature unless the room temperature is more than 30 degrees Celsius plus or minus 2 degrees. Cold chain to be maintained during transportation. So what is the technique of administration? Insulin is to be injected using the correct technique, ensuring proper hand hygiene, and injections are delivered to healthy subcutaneous spaces. Right, what are the frequently asked questions on basal insulin? What is the initial dose, which is 0.1 to 0.2 units per kilogram body weight? What is the preferred timing of injection? Any time of the day at the same time? Can oral diabetics be continued with basal insulin? Appropriate oral antidiabetics can be continued. What is the titration regimen? can be safely titrated using daily, once in 3 days, or weekly titration schedules. Up to what dose can basal insulin be initiated? It is 0.5 units per kilogram per day. Can basal insulin be prescribed in special population like elderly, CKD patients, pregnancy? Yes, definitely. So what is the in-hospital management of hyperglycemia? If the patient is in the ICU, your target should be around 140 to 180 milligrams per deciliter with the regular human insulin, which can be administered as infusions. Generally, with the recent guidelines, we avoid sliding scale insulins. Adjust insulin infusion rate based on the blood glucose values. If the patient is not in the ICU, maintain a fasting of 80 to 120 milligrams per deciliter, pre-meal less than 140, post-meal less than 180 milligrams per deciliter respectively. The insulin, that is the basal insulin or bolus insulin, which is an analog, is preferred with a route of administration of subcutaneous. So what is the total dose calculation? That is the total insulin needed in the past 24 hours, 50% basal, 50% bolus, individualized correctional bolus. So avoid sliding scale insulins. Right, as already Bhupal has mentioned, with because most of the diabetics and hypertensives go hand in hand, AC inhibitors and ARB controversy. Hypothesis: patients treated with AC inhibitors and ARBs will have increased number of ACE2 receptors in their lungs. ACE2 receptors serve as binding sites for the anchoring spike proteins on exterior surfaces of coronavirus. There may be increased risk of severe disease outcomes due to COVID-19 in patients using ACEs and ARBs. This speculation about the safety of ACE or ARB treatment in relation to COVID-19 do not have a sound scientific basis or evidence to support it. So physicians and patients should continue treatment with their usual antihypertensive therapy because there is no clinical or scientific evidence to suggest that treatment with ACE inhibitors or ARBs should be discontinued because of COVID-19 infection. So finally, coming to the last slide, key considerations. People with diabetes have increased risk of developing infections, including COVID-19. People with diabetes have greater chances of serious complications from COVID-19. Risk and severity of COVID-19 in people with diabetes can be reduced with general precautions, the good glycemic control and proper monitoring. When anti-diabetic medications are considered for temporary dose reduction or discontinuation, basal insulin plus or minus bolus can be used for good glycemic control. And insulin is the preferred agent for control of hyperglycemia in hospitalized patients. Thank you.
Thank you, Dr. Umakant, for a very lucid presentation. How is the treatment of steroid-induced diabetes? Is it any different from the conventional diabetes as you type 2 diabetes, or?
No, sir. We need to maintain the euglycemia status. So depends on how the blood sugars are in the fasting and the post lunch. In that cases, we give basal insulin at night with short-acting boluses of, for example, Epidra, that is insulin glucine, in the morning and afternoon, that is before breakfast and before lunch. So we combine basal bolus or basal bolus plus.
And what has been your experience with how long have they needed? Suppose in the person who was not diabetic before has steroid-induced diabetes now, and in follow-up, how did you titrate?
Actually, in hospital, we used to check the blood sugars hourly. We used to fix the basal insulin according to the body weight, and we gave morning and afternoon short-acting, that is insulin glucine. That is bolus and bolus plus, depending upon his blood sugars. And at the time of discharge from the intravenous steroid, the consultant pulmonologist used to prescribe oral steroids. So based on the doses for the last 5 days or the 7 days of in-hospital stay, we used to calculate the total number of units, divide it and make it as basal insulin, plus we used to add oral anti-diabetic agents and ask the patient to check at least daily once his fasting blood glucose, because it is always fasting first.
And after about a follow-up of how many days they were off insulins or oral hypoglycemia?
These patients, some of them used to take quite long periods. One, because of the diet, two, because of the steroid. So along with the prescribed diet and the prescribed diabetic medications, most of them, once the steroid is stopped, after a period of 1 week or 2 weeks, the patients have become euglycemic. But in some, we had to continue, not in some, in many, we had to continue at least the basal insulin for more than a month. And some are continuing it because they have been diagnosed now with diabetes.
Okay, if there any other questions? Dr. Srikanth? There are no questions. We'll go on to the second talk. Dr. Pavan Kumar P, who is a nephrologist working presently at Capital Hospitals, Vijayawada. He did his MBBS from Kuppam in 2002, joined in 2002, and subsequently MD from Vaidehi, Bangalore, and DM from PSG Institute, Coimbatore. He is well versed in intensive care nephrology, dialysis, renal transplantation, and has a short stint in Capital Hospitals now has a very good team of doctors along with him. And I invite him to talk on non-renal indications of dialysis. This is a pressing indication, and with the advances in dialysis, the non-renal indications are also being done more frequently now. I request Dr. Pavan Kumar Perugu to take over.
Good morning, everyone. Am I audible, sir?
Yes, sir. Yes, sir. Yes, sir.
Yeah, please go continue, Pavan.
Good morning, everyone. I am Dr. Pavan Kumar. I am a consultant nephrologist at Capital Hospitals, Vijayawada. First of all, I want to thank the CME 2020 from IMA Tenali for giving this opportunity to talk on this non-renal indications of extracorporeal therapy. And I am glad one of the pioneer nephrologists in coastal region, Dr. Rahul Srinivas Garu, to chair this talk. Let's proceed with the talk today, non-renal indications of extracorporeal therapy. These are the common extracorporeal therapies available today: intermittent hemodialysis, continuous renal replacement therapy, hemoperfusion, and plasma exchange. These are the various types of intermittent hemodialysis: hemofiltration, hemodiafiltration, hemoadsorption, SLED, that is sustained low efficiency dialysis, and ultrafiltration. Let's go to the basics of dialysis. The dialyzer contains 4 compartments. One is blood, the other one is dialysate. Both of them are separated by a semi-permeable membrane which contains pores and a membrane supported structure. There are 3 types of dialyzers. One is depending upon the pore size in the semi-permeable membrane and the surface area for filtration. They are divided into low, intermittent, and high flux dialyzers. Let's go to the basics of dialysis. The concept in dialysis was we'll be running the blood and dialysate in opposite directions in the blood and dialysate compartments. Because of difference in concentration gradient, the molecules will be running from the high concentration gradient to the low concentration gradient by diffusion process in hemodialysis. Whereas in hemofiltration, We will be giving substitution fluid, thus by forcing the plasma from the blood space into the effluent, there because of the solvent drag, the molecules will be pushed towards the effluent. This is the hemodiafiltration, the third one, simultaneous use of both hemofiltration and dialysis, that is convection and diffusion. Both of them we are using in hemodiafiltration. Ultrafiltration, here we are not running it, we won't run any dialysate, just will be removing the fluid, extra fluid, whatever is there in the patient's body. Adsorption, here the large molecules adhere to the surface or interior of the membrane in the dialyzer. Thus we are removing the molecules. Depending upon the molecular weight of molecules, they are categorized into small, intermediate and large molecules. Less than 3,300 Daltons are small molecules like our urea, creatinine. Large molecules are more than 5,000 Daltons like our plasma proteins, cytokines. According to the molecular weight, the small molecules are usually removed by diffusion. The middle molecules and large molecules are usually removed by convection. More than 50,000 Daltons, that they are usually not removed by dialysis. It's the diagram showing the various molecules, how they are removed by hemodialysis, hemofiltration. The molecular weight is more than 50,000 Daltons. It's better not removed by dialysis, hence therapeutic plasma exchange is indicated. This is the evolution of various dialysis machines. This is the first dialysis machine that was used in Netherlands, and we can see the evolution of dialysis machines. These are the dialysis machines available today. The first one is a regular dialysis machine. Here we can do only the hemodialysis in this. The second one is HDF machine, hemodiafiltration machine, wherein we can use it for hemodialysis, diafiltration, filtration, everything we can do with this. And this one is the advanced CRRT machine. This is the composition of our dialysate, what we use in hemodialysis and peritoneal dialysis. Here we have the provision to adjust the concentration of sodium, potassium, calcium, and bicarbonate. If the patient is having severe hyponatremia, we can adjust the sodium levels so that we can add only 10 during dialysis. Potassium, if the patient is having low potassium or high potassium, we can change the concentrations of potassium. Similarly, calcium also we can change. If the patient is already having a severe metabolic acidosis, not getting improved by conventional methods, we can do dialysis for that also by changing the concentration of bicarbonate. This is how we'll give the dialysis prescription. First one, to decide the duration of dialysis, anticoagulation, whether required or not required, whether contraindicated, fluid removal, whether indicated or not indicated, if indicated, whether patient will tolerate or not. Blood flow, we have to decide patient on the blood flow and dialysate flow, both we will decide depending on the patient's hemodynamics. And any special dialysate solutions are required, whether low calcium, high potassium, low potassium. Coming to the topic per se today, management of extrarenal indications of extracorporeal therapy. First one is hyperkalemia, hypercalcemia, hypernatremia. These are dyslipidemias. After trying all the conservative methods, if the electrolyte abnormalities are uncorrectable, then we can try hemodialysis depending upon the patient's hemodynamics through a normal dialysis machine or CRRT machine. Hemoperfusion. This is an extracorporeal therapy wherein the heme absorption technique is used. These are the filters available for heme absorption, wherein these filters contain a small cells within which activated carbon or some resins like polystyrene will be there. Here we'll be running the patient's blood through these filters. There the toxins or drugs, they are absorbed into the cells and thus it can be removed. These are the two filters available for hemofiltration. This is a census showing how the drug extraction ratios are for various drugs in our day-to-day practice and poisons also. This shows the removal will be well with resin hemoperfusion. These are the various drugs what we use in day-to-day practice. If accidental drug overdose happens, we can try hemoperfusion. Antidepressants, phenobarbital, barbiturates, some antibiotics like ampicillin, clindamycin, vancomycin, paraquat poisoning. Our experience is with paraquat poisoning. Regularly, we'll be using hemoperfusion for paraquat poisonings Unfortunately, none of them has improved, and studies also haven't shown any special benefits in this also. XTRIP, it is a international collaboration work group comprising of various nephrologists, clinical toxicologists, pharmacology, and critical care specialists. They'll be evaluating the benefits, risks, and cost of the various hemoperfusion techniques, and they'll provide guidelines. And it was supported by more than 30 professional societies, and they'll be giving guidelines and for hemoperfusion or other extracorporeal therapies for poisoning. Currently, they have approved more than 24 poisons. These are the recommendations by them for hemoperfusion. Poisons like organophosphates, paraquat, methylene poisoning, ethylene glycol, and some drugs like lithium and all they have suggested. This hemoperfusion, we can run the filter for 3 to 4 hours with a good blood flow of minimum 200 ml per minute. After that, even if you use also, it won't be useful. And if you want, you can repeat the session after 6 to 12 hours, depending upon the patient characteristics. Plasma exchange. This is the way we'll do plasma exchange. The blood will be run through a plasma separator, from which the plasma and some plasma proteins are removed, and simultaneously we'll be replacing replacement solution, either albumin solution or fresh frozen plasma, and this is the way the effluent comes out, and purified plasma will be given to the patient plaque. These are the various pathological substances that can be removed in plasmapheresis. Various immunoglobulins, autoantibodies, especially in case of connective tissue disorders or myasthenia gravis, circulating immune complexes, and protein-bound substances and toxins. These can be removed in plasma exchange. Usually, they'll be having a molecular weight of more than 50,000 Daltons, which cannot be removed by normal hemodialysis. The substance what we are planning to remove in plasmapheresis should have a large molecular weight and long half-life, and it should be acutely toxic and resistant to conventional therapy. For example, in anti-GBM disease, IgG molecules will be there, and it has a molecular weight of more than 1.5 lakh Daltons. The half-life of IgG was around 21 days. If the patient is having an acute attack of IgM anti-GBM disease, we can suppress the further formation of IgG by immunosuppression or steroids. But whatever the antibody immunoglobulins that are there in the body, it takes 21 days to reduce the amount to half. So there this plasmapheresis is indicated. These are the various indications for plasmapheresis. Neurological indications like Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, myasthenia gravis, multiple sclerosis, autoimmune disorders, SLE and other autoimmune disorders. Whenever they have a flare in neurological manifestations or hematological manifestations, we can give plasmapheresis. Autoimmune hemolytic anemia, pure red cell aplasia, antiphospholipid antibody syndrome, atypical HUS. These are the various indications for plasmapheresis other than renal indications. We can do plasmapheresis in two methods. One is centrifugal separation, the other one is membrane separation. This is a normal dialysis machine what we use. We can use a separate filter and we can do plasmapheresis in this. But usually for running plasmapheresis in this, we need a central line access. Requires good blood flow and central line access. Whereas this is a machine what we use in blood banks for cytopheresis, for separation of plasma or platelets or anything. With this also we can do a plasmapheresis. Here the peripheral line is enough and a minimum blood flow is enough to do plasmapheresis in this machine. Central line is not required. Advantages of membrane filtration: filtration will be fast, but removal of substances substances will be limited, and here apparent anticoagulation is required. For doing centrifugal plasmapheresis, we need citrate anticoagulation. It is a bit expensive, and loss of platelets will be there in this. Choice of the replacement solution: when we are removing plasma, we have two options. One is albumin and fresh frozen plasma, depending upon the patient's characteristics. When we give albumin, this ABO incompatible issues won't come, and it depletes inflammatory mediators. Albumin bound toxins and all will be removed, and there is no risk of hepatitis. Disadvantages with albumin replacement are it is very expensive and it doesn't contain any coagulation factors or immunoglobulins which are present in fresh frozen plasma. This is the advantage of fresh frozen plasma. And disadvantages of fresh frozen plasma are allergic reactions, hemolytic reactions, and in vivo incompatibility and risk of communicable diseases. This is how we'll calculate the plasma volume, how much to remove and all. Total blood volume multiplied by 1 minus hematocrit. Depending upon the requirement, we can give a low volume plasmapheresis or high volume plasmapheresis. Low volume plasmapheresis is one plasma volume, usually 40 ml per kg. High volume is 1.5 times the plasma volume, it is 60 ml per kg. These are the complications of plasmapheresis: hypotension, bleeding, edema formation, thrombocytopenia, and anaphylactic reactions. These anaphylactic reactions can be secondary to our FFP what we transfuse or can be due to the filter per se. Usually we'll see a bloody effluent that gives us an idea whether it is any anaphylaxis is there that causes hemolysis. Hypotension can be secondary to hypovolemia or the blood running in the circuit or dialyzer. As we remove it, then that also will cause hypotension. Bleeding can be due to loss of clotting factors in plasmapheresis or because of the disease per se. Double filtration plasmapheresis, this is usually we'll do in desensitization in incompatible renal transplants. Here we have two filters. First one is a plasma separator. It's a normal membrane filtration what we use in our normal dialysis machine. After filtration, we'll be running the filtrate into the second one. It is called plasma fractionator, wherein the small molecules will be absorbed back and the large molecules will be removed and the filtered plasma will be recirculated. Again, it is transfused into the patient's body. So there is no much loss of plasma. So hence we can use albumin as a replacement solution in this. And immunoglobulins and albumin, the small molecules will be absorbed and only this immunoglobulins and albumin, whatever large molecules, that only will be released in double filtration plasmapheresis. These are the advantages. It is more selective, removing only the large molecules. Purified plasma will be returned, so there is no need for lot of replacement and minimum albumin loss. No FFP is required. This is the diagram showing a conventional plasma exchange wherein we are removing all the molecules, and this is double filtration plasmapheresis. Wherein we are removing, depending upon the filter size, we are removing the whatever molecules we require, that only we are removing here. This is double filtration plasmapheresis. Liver diseases and extracorporeal therapy. Unlike our renal toxins, the hepatotoxins are albumin bound and they are lipid soluble. And doing extracorporeal therapies in liver failure patients is challenging because of poor hemodynamics and high risk for bleeding. These are the various hepatic toxins: bilirubin, bile acids, aromatic amino acids, mercaptans, and so on. These are the various indications for extracorporeal therapy. Acute liver failure, whatever may be the etiology, we can use in acute liver failure. Chronic liver failure complicated by some sepsis or some GI bleed or subacute bacterial peritonitis and hepatorenal syndrome. This is a very inexpensive and baseline extracorporeal therapy for liver failure available. Here we are not running any dialysate. We will be using a high flux dialyzer. In that, we'll be using albumin solution as a instead of dialysate. We are running the albumin solution at 30 ml per hour. It is well tolerated as we are infusing albumin and all in hemodynamically unstable patients also. We can do it as a regular dialysis machine. What happens was here, whatever the albumin bound toxins that are there, there is a absorption of albumin bound toxins to the albumin whatever we are infusing. That's how we are removing the albumin bound toxins. Here, whatever albumin we use that is not recirculated, it is discarded. This is single pass albumin dialysis. The extended form of this is single pass albumin extended dialysis. Here, if the patient is having a renal failure along with the liver failure, we can use one more filter. We can use one more filter and we can do dialysis also. In one filter, we'll be running only the albumin solution wherein the toxins will be released and the blood is passed to the other filter where the dialysis will be happening. Evacuo filter. This is a specialized filter designed for plasmapheresis wherein You can do both plasmapheresis and dialysis. It is a high flux dialyzer, well used in liver failure patients. This is how it was connected. It can be used only in HDF machine or CRRT machine only you can use. This is a HDF machine wherein you are using the evacuate filter. We can do high volume plasma filtration. Here we have done around 1600 ml of plasma filtration over 6 hours, a good volume for a liver failure patient. And we'll be running the dialysate also so that acid-base balance will be maintained. This is the advantage of evacuate filter over normal plasma filters. Both dialysis and plasmapheresis can be done. This is the most advanced molecular adsorbent recirculation system. This is a machine. It can't be used alone. It has to be used along with the dialysis machine. This is the machine and this is the circuit. Here what we'll be using is, here it has three circuits: blood circuit, albumin circuit and dialysate circuit. Here in the mass, this is the high flux dialyzer. Here the albumin bound toxins will be removed, and after that it will run through this circuit where albumin will be flowing on, and then it goes into the low flux dialyzer where some dialysis and all happens. After that it passes through a two filters. One is activated charcoal filter, and this is a resin filter where the all the toxins are removed, and after that it is passed again into the patient's returned into the patient's body. This is how we use the Mars machine along with the dialysis machine. Mars can be used 8 hours daily or on alternate days. Disadvantages are thrombocytopenia and arrhythmias. Very costly procedure, costs around 2 lakhs per each session. And various trials have been done on Mars. All of them have showed equivocal results, but mortality has come down by 30% in most of the studies. It's a good number. Prometheus system is nothing but the similar component, similar to Mars, but from another manufacturer. These are the filters available for isolated bilirubin removal. Like what we do in hemoperfusion, here we'll be running blood through these filters where the bilirubin is removed by hemoadsorption. Cardiorenal syndrome. Indications for extracorporeal therapy in cardiorenal syndrome are refractory heart failure, post-cardiac surgery, acute pulmonary edema, post-cardiopulmonary bypass, severe LV dysfunction complicated by sepsis. Here we are not running any, we won't run any dialysate. We'll be doing only ultrafiltration. If the patient's hemodynamics are better, we can do ultrafiltration through a normal dialysis machine. Or if the patient hemodynamics are poor, then we have to do slow continuous ultrafiltration by a CRRT machine, which is slow and well tolerated. These are the advantages of ultrafiltration. If you use loop diuretics, unpredictable removal of sodium and water will be there. Here, the diuretic responsiveness is well maintained. Electrolytes won't be lost in ultrafiltration, and improved outcomes compared to the diuretics. Sepsis, it's common in our day-to-day practice. The inflammatory mediators that are implicated in sepsis, or these are the main inflammatory mediators involved. All of them are having a molecular weight equal to that of large molecules. These are well removed by hemofiltration. Apart from our regular antibiotics and other supportive therapies like vasopressors, we can try hemofiltration in these patients with severe sepsis, documented severe sepsis, wherein these inflammatory mediators will be removed. A lot of studies have been done, and they showed a good removal of IL-6, tumor necrosis factor alpha. These things and all were calculated and monitored in the effluent also. A good removal of around 30 to 40% decrease in all these levels have been documented. A lot of studies are yet to be done on this, but whatever studies that have done, they have shown some benefit. Some special dialysis filters are available for sepsis cases. First one is Oxaris. This filter is designed for removal of both endotoxins and cytotoxins. It has a heparin coated membrane wherein thrombosis and all won't happen even in cases of DIC. The other one is, it is made up of polyethylene amine. It binds all the negatively charged ions like endotoxins, and the membrane which is here, AN69 membrane, which it binds the cytokines. One of the common filter well used in sepsis, and especially during this COVID times, lot of studies have been done on this auxiliary filter, and lot of studies have shown proven benefit in sepsis, and whatever inflammatory mediators that are there in the COVID patients also, it was well removed. Lot of studies have been done and they have shown good benefits. These are the features of auxiliary filter. You can use the filter for around 24 hours and it removes both endotoxins and cytokines. We can run dialysis also in this. Along with same filter, we can run the dialysis also and maintain the acid-base balance. Costly, one filter costs around 70 to 80,000. It is used only in CRRT machines. We can't use it in the other machines. Lot of trials have been done. These are all the trials that were done from the past 1 year in COVID cases. All of them have proven some benefit in removing the inflammatory mediators, endotoxins and cytokines. One more filter is cytosol filter. It was designed for removal of cytokines only. We can't run dialysis in this. It is designed to remove the molecules of this range. It can be used in any machine. We can use it in a normal dialysis machine also. Only cytokine removal. We can't do dialysis in this. And whatever trials that were done on this have shown poor results. This is how we use cytosol machine. This is a normal dialysis machine, and this one is CRRT machine. Antibiotic coated filters. Polymyxin B has been tried as a antibody coated filters, but efficacy in septic shock is still under debate. Lot of studies have been done, but none of them have proven any benefit except this Abdom mix. They have shown some benefit in abdominal sepsis cases, but none of them are recommending this filter. Some special indications. ARDS. Lot of inflammatory mediators are implemented in ARDS. Hemofiltration with CRRT machine, prolonged slow dialysis is highly beneficial in ARDS cases. Here we'll be removing dual advantage with hemofiltration in ARDS was one will be removing all the inflammatory mediators. The second one will be removing some fluid also, wherein there is no extravascular lung water increase. It reduces the extravascular lung water, thus reducing the pulmonary capillary wedge pressure. Along with removal of mediators and water, we can have an acid-base balance, wherein the bicarbonate levels will help in maintaining the permissive hypercapnia. Rhabdomyolysis, whatever may be the cause for rhabdomyolysis, whether it is drug-induced or trauma, adequate fluid resuscitation and combined with urinary alkalinity is the mainstay of treatment. The presence of myoglobin in the filtrate by hemofiltration has been demonstrated. The molecular weight of myoglobin is 17,000 Daltons. It has been documented in the filtrate also. We can use hemofiltration for the removal of myoglobin levels. Lactic acidosis, whatever is the modality of dialysis we use, total body clearance of lactate was only 0.5 to 3.2%. Studies are going on for removal of lactates by dialysis, extracorporeal therapies. Here we can use hemodiafiltration in lactic acidosis, even though it is not so beneficial to minimize hypervolemia and hypernatremia, which are complications of bicarbonate infusion, whatever you give to encounter the lactic acidosis. Even if you found some reduction in lactate levels during hemofiltration, studies showed that it is not secondary to the removal. It is secondary to improvement in acid-base balance that led to enhanced lactate metabolism. It is not secondary to lactate removal. In CRRT, we have a solution called bifossil. It is a lactate-free solution. You can use this in severe lactic acidosis, but studies are yet to come on this bifossil solution. Tumor lysis syndrome, accumulation of uric acid crystals in the tubules and calcium phosphate complexes in the hyperphosphatemia are implicated in renal failure. And these are very small molecules, uric acid and calcium phosphate complexes. They can be removed by conventional hemodialysis if the patient is stable hemodynamically. Otherwise, CRRT is used. This is a specialized filter wherein you can use for uncorrected hypercapnia. This is a filter wherein all the conservative modalities fail. Then you can do dialysis through this filter where it removes the excessive carbon dioxide. This is the most advanced CRRT machine. The advantages of CRRT over the normal regular dialysis cells, this is a slow continuous process wherein the fluid management and volume solute clearance will be slow and continuous, and it is adaptable. There won't be any hypotensive episodes because we can, depending upon the patient hemodynamics, we can come down with the blood flow up to 40 ml per minute also. In normal dialysis machine, we can have a minimum blood flow of 100. Depending upon the patient's hemodynamics, we can come down with the blood flow rate, thus preventing the hypotensive episodes, and continuous control of uremia, electrolytes, and acid-base balance. Nutrition also is well maintained. We can use all modalities of dialysis in this hemofiltration hemodialysis. It has a better hemodynamic stability compared to other machines. There is no RO water supply required. Sterile solutions are available. With them only we'll be using as a replacement fluid or dialysate fluid. Lot of compositions are there in that sterile solutions, depending upon our requirement: low potassium, high potassium, lactate free. It is a compact machine. It can be used bedside. Blood flow, compared to the other machines, we can come down with the blood flow to minimum of 40 to 60 ml per minute. ECMO and CRRT, the patient is on ECMO for severe hypoxia or any other cause, CRRT machine is the only one we can connect with the same circuit. Same ECMO circuit we can connect the CRRT machine, and thereby we can maintain the acid-base balance, fluid removal and fluid balance. If we maintain the acid-base balance, then that can maintain the bicarbonate levels, carbon dioxide levels, and permissive hypercapnia levels. Only machine that can be connected with ECMO was CRRT machine. These are some rare indications: hyperammonemia or hepatic encephalopathy. Ammonia is well removed during dialysis. So normal, if the patient's hemodynamics are stable, you can use a normal dialysis machine for hyperammonemia patients. Vacuomesis, extracorporeal therapies are advancing in various non-renal indications also, along with renal indications. Separate filters are available for various systems, for poisoning, liver disease, liver failure cases. CRRT is an advanced dialysis machine both in renal and extra-renal indications. Thank you.
Thank you, Pawan, for a great overview of all the dialysis in various non-renal indications. Just any of your practical experience where you have used this with good success? As rightly said, paraquat poisoning, there have been mixed results.
Yes, sir. Paraquat poison, we have done good amount of hemoperfusion, but depending upon the presentation and depending upon the time lapse between the consumption and presentation, results vary. But we had patients presented very early, 3 to 4 hours after consumption, but none of them required. But we will give 2 sessions, 12 hours apart on day 1 itself. And second day onwards, we'll give 2 sessions, but none of them required. Along with that, hemoperfusion, we have given other drugs also, steroids, cyclophosphamide, everything we tried, but none of them has improved. Paraquat is the, we had a good experience of hemoperfusion in paraquat only.
Apart from that, any other these things like refractory pulmonary edema?
Arsenophosphoras we never tried, sir. Actually, they have given indications, but we never tried, sir. I personally haven't tried hemoperfusion for any other poisons or drugs.
Mm-hmm. Yeah, some of them have been useful, acceptable. Barbiturate poisoning are definitely very useful. Second is fluid overload, which is not responding to diuretics, especially in, as you mentioned, theoretically in congestive cardiac failure, refractory cardiac failure, cirrhosis, where the fluid overload is not responding to diuretics, severe hypoalbuminic conditions where they are not responding. If you remove 3 to 5 liters of fluid, and then subsequently you see that the diuretic starts acting.
Yes, sir.
That's one of the very good aspects. And as you rightly pointed out, dialysis is something, the term indicates that removal of fluid and waste products. but the way it has to be used, it's even in renal failure, where we do routine dialysis, there are small subtle changes in each and every patient, which when used or applied practically, we have good results. It's not just a technician-based thing, which can be like you give a prescription and a lifelong take dialysis. It's a process which has to be understood. There are a lot of changes we can make in the dialysis as per the patient's requirements, as per the disease, and see the outcomes accordingly. And understanding the pathophysiological basis of working of a machine, the supplementation, how it improves the fluid dynamics is very crucial. And as you rightly pointed out, the various filters also, which filter when to use. Even I may not be knowing all the filters which are available also. That many filters and different varieties are there. When rightly applied, gives good results.
Our center where I have done my DM, sir, we have good liver transplant in it. We have
Yeah.
positive results with plasmapheresis in liver failure cases.
Yeah, that's what a good unit with a practical backup is a very useful asset to any hospitals, where you can take up the challenging cases and evolve accordingly to the requirements. Thank you very much. If there are any questions from other chairs. Shrikant, if there are no further questions, we'll hand over the session back to you.
Thank you, sir. Thank you very much, sir.
Thanks a lot, sir.
Thanks,
you for
Dr.
giving me
Pawan.
this opportunity.
We thank the chairpersons and also Dr. Pawan and all the team of Capital Hospitals who ran the first session of Sunday very successfully, all the speakers and chairpersons. We'll meet again at 12 noon for the fourth and fifth session for pediatrics and gynecology. Thank you.